Hello and welcome to the Dementia Doctor. Today we have Dr. Acosta with us. So we would first like to know a little bit more about you. Tell us a little bit more about yourself, Dr.
Yes,
Acosta.
so I'm an associate professor of neurology at Vanderbilt Health, which is in Nashville, Tennessee. I finished my neurology residency at the University of Virginia, then did fellowship in behavioral neurology at the University of Florida. And I've been practicing at Vanderbilt, specializing in patients with dementia for the past 13 years.
So we are very lucky to have you here. And one of the conditions that's not so much talked about in dementia clinics or even outside is something called as NPH or Normal Pressure Hydrocephalus.
Yes.
What does this mean?
Normal pressure hydrocephalus is a condition where there's extra fluid that accumulates in the brain, and that typically leads to a triad of common symptoms of what we say in medical school is weird, wet, and wobbly. So weird, they can have neuropsychiatric symptoms. So some patients have changes in their cognition or sometimes even personality changes and things like that. It can look like short-term memory, almost like Alzheimer's disease sometimes. And so that's the weird. The wet is they develop incontinence, so they can lose control of their bladder specifically. Sometimes in more advanced cases, they can lose control of their bowels too, but it's primarily urinary difficulties. And then the third part of it is wobbly, is that they have changes in their walking. And so patients have classically what's described as a magnetic gait, where it seems like their feet are almost stuck to the ground and it's really hard for them to initiate walking or even just lift up their feet.
Yes, thank you so much. It's something that I've not had a lot of people ask for. So a lot of people, when they come to the clinic, they will say, "Oh, do I have Alzheimer's?" It's not something that's very commonly talked about. What do you see in your clinics in terms of the awareness for this condition?
It's not very well known. I think we've had more exposure with a local, not local, but a celebrity, Billy Joel, musician,
Oh, okay.
who has been diagnosed with NPH. That's been in the headlines. And so we've had maybe a little more uh, reference to that since Billy
Yes.
Joel had it. But it's one of those conditions where, as patients age, they can develop these kinds of changes in their urination and their walking from lots of other things. Orthopedic surgery could lead to changes in their walking. Men with an enlarged prostate can have changes in their urinary frequency, their ability to urinate. Or patients can have other things like a stroke or even Alzheimer's disease that can cause changes in their thinking. And so, because there's so many different reasons that can contribute to those symptoms, it's not something that comes to the forefront of patients' minds. And usually, even when they first see the doctor or even specifically a neurologist, NPH isn't necessarily high on the things that the doctors think about until they get the brain imaging. Because
Yes.
usually it's the classic finding of that extra fluid, so to speak, on the brain that really brings up the question of normal pressure hydrocephalus.
Yes, I absolutely agree. It's something that's so difficult to diagnose because those three symptoms, memory changes or behavior changes, the urinary incontinence, as well as the gait changes or changes in your walking, can be caused by so many different conditions, are common in older age. So it's hard to diagnose it. So it seems like MRI is a way to diagnose that condition in addition to the clinical features.
Correct. MRI is a lot more specific in terms of the accuracy and the clarity of the images as opposed to a CAT scan, even though sometimes you can see a preliminary change also on a CAT scan. But usually we do recommend getting an MRI for that clarity of imaging.
What are there any other studies you recommend for this particular condition?
Usually getting some sort of cognitive screening, whether it's performed by a general neurologist or a subspecialist like me, that's really helpful just to get a sense of what cognitive aspects have changed in a patient. So that's typically helpful. And then there's a whole workup that we recommend. The International Movement Disorder Society actually put out a recent set of guidelines recommending how patients be worked up. And so that usually involves a procedure called a spinal tap and doing assessments before and after the spinal tap, where fluid is getting removed out of the lower back to see if patients have an improvement in the walking and the thinking and the ability to go to the bathroom by doing these assessments before and after that spinal fluid is removed.
In my understanding, usually the gait is the one that responds the best to the lumbar puncture or the spinal tap. Would you say that's what your experience is, or is it different from that?
I would say that's accurate. By and large, the first symptom that people will typically develop is the changes in the walking, and then afterwards they'll develop maybe changes in the cognition, maybe changes in the urination. Somebody doesn't have to have all three, but it's pretty common to have all three. And so correspondingly, after they get the spinal tap, the way the symptoms usually respond to first is the walking, then maybe the cognition, then maybe the urinary symptoms.
Oh, okay, okay. So if someone does a spinal tap and their walking improves, what should they be doing then?
Mhm. Usually, that evaluation is done in conjunction with a neurologist.
Mm-hmm.
And so, typically, the neurologist would then make a referral to neurosurgery because when we take out that spinal fluid, that's really just a temporary measure to see if they have that degree of improvement. If there is improvement, the permanent solution to that, because most people don't want to come and get a spinal tap done every so
Yeah.
many months, nor would we recommend that, but they would get referred to neurosurgery because the permanent solution to that would be getting what's called a ventriculoperitoneal shunt, where the neurosurgeon puts a shunt that drains the fluid from the brain through a tube that goes down into the abdomen. And so
Mm-hmm.
some of that extra fluid gets drained to the abdomen. Typically, that will cause a more lasting improvement to the temporary symptomatic improvement that we see after the spinal tap.
Now, you've had extensive experience in this field, and so I'm really curious, how do you counsel families in terms of if they do undergo a shunt placement,
Mhm.
what will improve and especially in relation to memory and thinking, would
Mhm.
that improve or how much improvement would they see?
Mhm. Typically, the best way to predict what's going to improve long term is how they responded to the spinal tap. And so that's why we're really careful about how we measure. That's why I really stress doing those pre and post spinal tap assessments. If we can get objective measures, so we, for example, have a protocol for NPH at my institution where patients are getting a neuropsychological assessment. They're getting physical therapy assessments before and after the spinal tap. They're getting seen by, they're doing a neurological exam before and after the spinal tap. And we've got specific measures that we're taking or numbers we're writing down so we can objectively quantify as much as possible that level of improvement. We certainly factor in any observations the patient or family may also have, but I think it's really important to have both those subjective and objective components to gauge that, because typically that will predict patient's response to the shunt. And so that's why that we get a better sense overall of how they're going to do after that spinal tap.
So seems like it's very patient specific. What
Mhm.
the data around the spinal tap shows you is what would be the best prediction for them when the spinal tap is or the shunt is placed.
Yes.
Um, are there any general predictions that we could kind of give in terms of directions to the family that, oh, most likely it will help with the walking
Mhm.
or the memory or things
Mhm.
like that?
So, walking is a symptom that's most likely to improve. Second most likely to improve would be if there are any changes in memory and thinking. The last symptom to improve potentially would be the urinary changes. It's really hard to predict in any one individual case because at the bottom, at the end of the day, we don't really know exactly what causes normal pressure hydrocephalus, and there's so much variability in the timeline by which patients come to see the doctor. Maybe they've had symptoms for 6 months, maybe they've had symptoms for 5 years, and it sometimes gets misdiagnosed as something else. Oh, it's just your prostate. Oh, it's because you've got, a weak bladder because you've had 7 kids. Oh, you've had that knee replacement, and that's why you're having the changes in the walking. And so it's really hard to predict sort of the degree to which somebody is going to have improvement because the length of time with which they've had symptoms has been so variable. Ideally, it is something, though, that we would want to try to treat as soon as possible because, generally speaking, the sooner we can address it, the better people have a chance of improving.
And I've also heard that this sometimes goes hands in hand with Alzheimer's disease. Is that
Mhm.
commonly seen as a disease with NPH or no?
Yeah, I was just having a conversation with a colleague about that the other day, where we also get Alzheimer's biomarkers actually on the spinal fluid on the patients that we run through our NPH protocol at Vanderbilt. And I'm always surprised by how infrequently these patients have Alzheimer's positive
Oh,
biomarkers. And so it's really the minority. And I
okay.
mean, there's also some other literature that has shown that even NPH itself, it kind of changes the biomarkers for Alzheimer's disease and spinal fluid, so it's not 100% reliable.
Uh huh.
But it's not something that exists necessarily frequently, so it's not something that always goes together.
Oh,
I
okay.
have a hand. I have a handful of patients that I've seen where I have truly diagnosed them with both. One patient that comes to mind was a woman who I personally followed for Alzheimer's disease, enrolled her in a clinical trial for Alzheimer's disease, and of course she passed all those tests to be enrolled in that clinical trial. And then a few years into her disease, really started developing some specific gait changes
Mm-hmm.
that we classically see with NPH, and thankfully had the benefit of earlier brain imaging that I was able to compare with more current brain imaging. Saw that extra fluid, those enlarged ventricles in the brain, and so we did end up shunting her, and she had improvement in her mobility, which was really important for her and her husband because they were really active and they loved to ride motorcycles and things
Oh,
like
wow.
that. So I do see rarely that they co-occur.
Okay, okay, good to know because I think in the field there has been this discussion and it kind of varies with how we measure for these Alzheimer's biomarkers and seems like the major problem with NPH is the fluid in the brain, the
Mhm.
way it is not taken out correctly. Is that how we think about the mechanism of the disease?
Yeah, we're not really sure if there's an overproduction of spinal fluid or if there's an underabsorption, or sometimes people can have, we're talking primarily is about what we call idiopathic normal pressure hydrocephalus, where we don't know why somebody develops this. But sometimes there are cases where somebody's had head trauma or they've had a stroke, and that does alter the fluid mechanics in the brain. But by and large, we're not entirely sure why. I think one myth I do want to bust about normal pressure hydrocephalus is people are always worried that that means that there's extra fluid or like it's pressing
Yes.
on the brain to a certain extent. But even the name itself, normal pressure hydrocephalus, means that the pressure inside the brain is what's considered within normal range. There's not extra pressure, not worried about things getting
Squeeze.
compressed, so to speak, in the brain. But it is something with the fluid dynamics we don't fully understand. We're still trying to figure that out. But that's what leads to those symptoms developing.
This has been very helpful. What would be your takeaway message for our families listening to you?
I think my takeaway would be it's, of course, really important to have that open communication with your physician to talk about these symptoms, and feel free to raise that question of, my either I or a loved one has these symptoms of changes in walking, changes in going to the bathroom, changes in cognition, either part or all of those three symptoms, and raise the question of, could this be normal pressure hydrocephalus? And try to get that brain imaging, try to get that assessment done if that is a clinical concern from the neurologist that you're seeing so you get the appropriate workup.
Thank you so much for being a part of this conversation and coming to our
Oh,
channel.
you're welcome. It's always a pleasure talking with you.
Thank you.